Hotbed Talk. So welcome back to day 2 of EBPOM USA, live from Atlanta, Georgia, with me, Monty Mythen. We're here at the first Perioperative Practicum. I'm back with Mike Grocott. Mike, how are you?
Really good, great day today.
Fantastic. And we have 2 guests, Dr. Paul Wischmeyer from Duke, North Carolina in the USA. Hi, Paul.
Hey, how are you?
And
Great to be here.
Dr. Denny Levett from Southampton in the UK. So, Denny, why don't you start? Tell us a little bit about what you do back at home, work-wise, and what you were talking about in the session today.
So I'm a perioperative physician from Southampton in the UK, and I'm also an intensive care physician. And so my job is to look after patients both before and after major elective surgery. And my research interest has been trying to optimise those patients by evaluating their fitness at the time of surgery and trying to optimise that preoperatively. And this afternoon I was talking about the use of objective exercise testing to predict patients' outcomes around the time of surgery.
Great. You also gave us an update on fitness overall. I hope I've taken this away correctly. If we're physically inactive, i.e. physically inactive means that we're, as you phrased it, a couch potato, for example, then that does relate to our chance of surviving in life irrespective of other disease processes. It's in itself as a risk. Yeah,
absolutely. I think it's a hugely important factor in health outcomes generally is physical activity and physical fitness, and that's becoming increasingly apparent with the current literature. And it's not really surprising that in the perioperative period your fitness predicts your outcomes, because it predicts your outcomes in life more generally. And one of the problems that we face in the Western world more generally is that there is an epidemic of physical inactivity. The advent of office-based jobs, a lot of time spent on computers has meant we are doing less and less as a population, and this has impacts on fitness, obesity, and these have very significant health implications that I think are not necessarily well understood by our patient population and not always emphasised by clinicians around the time of surgery. And
if I've got this correct, or some of those slides you showed, now I have a number of different risk factors for cardiac disease. The blood pressure things, the cholesterol things. If I stay very physically active, if I try really hard to work my physical activity, can I mitigate many of those risks without taking drugs?
Absolutely. And I think this is a really important point. All drugs have significant costs and side effects, and patients don't like taking tablets every day, and they're all associated with side effects. Exercise is beneficial to all those cardiovascular risk factors, and in fact it's becoming clearer. The American Heart Association produced a statement relatively recently suggesting that fitness should be the 5th vital sign, and that we should be using fitness to predict health outcomes more than we do. So if you're unfortunate enough to have high blood pressure or heart failure, if you exercise and are fit, your outcome from that disease is likely to be significantly better.
So now I try and row on a regular basis. I've got one of those rowing machines at home, similar to the rowing machine I think you've got, Denny, actually, which is a Concept 2 rowing machine.
Absolutely.
And I try and do, half-hour stints of about 5 up to 5 or over 5k in a half hour, a couple of times a week, and then try and do a 10k at the weekend. I do that because I think it's a combination of pushing myself, but also doing that resistance exercise to keep some muscle bulk up. Is that okay?
So, as in, is that sufficient exercise?
Not necessarily. There's more activity during the week than that, but is that better than watching television at least? Absolutely.
So the evidence is really clear. For each additional doubling of what you're doing as we sit here and talk, in terms of your maximum ability to exercise, you reduce your all-cause mortality rate by 15%. And I don't think there's any drug that has that effect. And if you look at cardiovascular outcomes and exercise and activity, there's been recently several meta-epidemiological analyses of the literature, and nowhere has it been shown that a drug intervention is superior to exercise in terms of reducing the outcomes of secondary prevention for heart disease. So if you exercise that much that you just described, that would be sufficient to put you in a low-risk category. And so it would reduce your risks of heart disease and of mortality overall. And I think the other thing that's really important for our patients to understand is that you don't all have to be down the gym running 15K. Actually, the biggest benefit in terms of reduced death rates is by moving from the very low fitness to the intermediate fitness group. So from doing nothing at all to even just doing a brisk walk every day will have very significant outcome benefits for very sedentary patients.
And the 10,000 steps a day idea, what a lot of devices now, including many of our mobile phones, count steps. Just keeping an eye on that. Is that
helps.
A good start?
It's a good start. There's not a huge amount of data yet looking at population studies as to whether those have definitely improved outcomes. But what we do know is if you're doing 10,000 steps, you'll be a lot better off than someone who's doing only 5,000 steps. And having a monitor helps improve compliance. So we know for any behavioural change is really difficult for patients who are doing very little or any of us who are doing very little exercise or physical activity at the moment. If you just keep a diary of what you do, that will double your compliance with the outcome. So if you give a patient a diary and say, ask them to exercise more, go for a walk once a day, just giving them the diary and them completing it, even if you don't look at it, will double the likelihood of them doing that extra exercise. So that's a really important take-home message. Tell the patients what to do, give them specific information, give them a diary and say, I want you to write down what you're doing every day.
Okay, now, last bit before I come to Paul. I've always been a bit lardy, and I'm still quite lardy, okay? Pictures are available.
Do we need to translate that for the web?
Is that a British aphorism?
Lardy equals higher body mass index.
Technical term.
Yep.
So I'm overweight, possibly borderline obese, okay, is one thing. So we can have a discussion about that later, but you know what I mean.
Yeah.
Should I worry, if I can just pick off one, should I worry more about the fat or the fit?
Fit.
Okay,
so there's a lot of the early literature looking at obesity and poor health outcomes didn't control for fitness. There's been recent reanalysis of a lot of that data, and it's quite clear that a lot of the extra loading with obesity was associated because of the reduction in physical activity. So for a patient is better to be a little bit overweight and fit than very underweight or the low BMI and unfit.
Okay.
And that's quite clear from the literature. And that's important to tell patients because if they struggle to lose weight, it's still important to exercise.
So don't get depressed about the fact that the wobble is still there. Just keep the fitness going. So great time to bring Paul Wischmeyer in. Paul, welcome back. We've talked before on Top Mid Talk. Great to see you again. Remind us about what you do.
So again, much like Denny, I'm one of these new generations of anesthesiologists who primarily don't practice in the OR, that take care of patients before and after surgery. So I'm also a critical care physician and a perioperative physician, and my work at Duke is focused on care of the patient in the ICU, but more and more care of the nutritional needs of the patient in the preoperative setting or the pre-injury setting. We see cancer patients as well, and in the post-operative or post-ICU or post-cancer setting. And then we also run an inpatient nutrition service. So I serve as a director of nutrition for Duke Hospital, where we're caring for patients through the continuity of care. And I think hopefully that's the future perioperative model for exercise nutrition and many other aspects of how we do perioperative care.
So I interviewed you relatively recently about the Perioperative Quality Initiative guidelines on perioperative nutrition, which is available on Top Med Talk. And the papers in anesthesia and analgesia, the infographics are free on poqi.org. Remind us about that infographic about the shocking statistics about nutrition perioperatively. Just remind us of that before we mix these two things together.
Absolutely. Just in brief, I think malnutrition is truly perhaps the largest silent epidemic facing healthcare today. We know that, for instance, in GI surgery patients, 2 out of every 3 patients coming for GI surgery are clinically, objectively malnourished at the time of presentation for surgery. But the real challenge is very few, and in a survey we did, less than 20% of centers have any screening tools available or any screening process available, and so they aren't being seen. But what we do know is that a malnourished patient coming from surgery has a 5-fold increase of risk of complications and 3-fold increased risk of mortality because of their malnourished state. And so the aspects of what that means for a patient's outcome is quite significant. And then most strikingly, we have found through research data in large, almost 1 million patient databases, that for every $1 we spend on simple oral nutrition supplements, these small protein drinks, we can save $52 in hospital costs. And these are the very things we know can make a difference in these surgical patients, but yet less than 1 in 5 patients that have clinical objective malnutrition are ever receiving these simple, low-cost, highly effective interventions.
And the interventions are the sort of drinks we'd all be familiar with that you can go to pharmacies and buy that
Absolutely.
have... Okay. Sounds relatively inexpensive. Sounds cheaper to me than a meal.
Absolutely. $1 or $2 a bottle at most.
Okay. Now, in the session we had, I'll bring Mike in now to push this forward. In the session we had, there's this continuous realization that there's a reluctance with us as physicians, practitioners, clinicians in the broadest sense, to prioritize nutrition and activity as probably one of the most important, or two of the most important things we do. We're straight into, have we got diseases and can we treat them with pills and with surgery? So Mike, try and pull that together for us.
Well, I echo that sentiment. One of the dominant themes to me from this afternoon's sessions was, if you like, the Cinderella nature of the activity exercise story, the nutrition story. They're not pharmaceuticals, they're not surgery, and it probably needs a pretty big cultural change for us as physicians who've been trained all about drugs and operations to focus on these as interventions which are of at least equivalent, if not in some cases better value. It's a problem because it's all a bit simple, that what you eat and what you do may have a greater impact than the fancy stuff that the physician has traditionally prescribed you. And my impression from the conversations this afternoon is that certainly in the United States, that is problematic from a payment perspective. So actually getting these kinds of services supported is much more complex because they're a little bit off-piece, they're a bit unconventional.
So that was a recurring theme, Paul, we're discussing now across 2 healthcare systems, was I know it's the right thing to do for my patients, but who's going to give me the money to do that? Help us with that.
Yeah, and this is really the challenge, and I think you've heard us all say it, that we need a fundamental culture change in medicine to realize the importance of this. You know, the numbers needed to treat for statins and for aspirin, are in the 1 to 20 to 1 to 80 range, but the costs and risks associated with those drugs are significant. We know that the potential improvement from nutrition and exercise is actually greater than that. The numbers needed to treat are smaller. The costs are far less, but yet insurance will pay for a $20,000 therapy or chemotherapy that has adverse reactions and has a very low effect rate, but they won't pay for the $40 we need, or $20 even we need for preoperative nutrition that we know can reduce infection 40% with 5 days of use.
Wow.
And so I think these are fundamental things. Exercise, I was so struck by the data that you presented that the exercise effects on tumor size and on cancer efficacy may be better than the chemotherapy itself, and nutrition, similar effects in surgical outcomes.
So that's what we were hearing in your session, was the fact that supervised exercise programs appear to be highly effective in patients who are going to have cancer surgery, who are getting chemotherapy. And again, the pushback was, who's going to pay for it? How do they find the time to do it?
As Paul said, I think it's a major culture change that's needed, and actually it needs to start at medical school.
Yeah.
There's a recent study published in the BMJ in the UK which summarised the amount of time we spend teaching medical students about exercise and physical activity. Over a 5-year course, they spent 4 hours talking about that, and over 120 hours talking about pharmacology, etc., etc. And I was recently talking to our first-year graduates, so they're called Foundation Year in the UK, about a talk called Exercise as Medicine. So much of the data I presented today in more depth. And I got an email soon after, so someone said, well, why doesn't anyone tell us any of this at medical school? And can you come and give this talk to all of the first-year graduates, because I think we need to know about it, which I thought was encouraging. But the fact of the matter is, if we don't teach people that it's important from day one, then they're not going to tell patients that it's important.
And I'll come to Paul with some similar data about nutrition in a second, but when we were at medical school, when I was at medical school, we weren't at medical school together, it's quite apart from BMI difference here, there's an age difference here as well. We had every Wednesday afternoon off for sport, and we went to do that. Has that been Do you know if that's been cancelled now so that people can get back to the computers and get back to learning about side effects of drugs? Or
I don't know. Actually, in Southampton, I believe we still do have Wednesday afternoons for sport.
Excellent.
But no one ever mentions the health benefits of it.
Okay. Paul, from the nutrition perspective,
great.
Similar story?
Yes, so similar studies have been carried out in the nutrition education of medical students, and we know that over 75% of U.S. medical schools teach no required clinical nutrition courses at all. And when they survey outgoing graduates of residency programs, registrar training programs, less than 15% of family practice and internal medicine residents, the primary care physicians of America and the world, less than 15% feel qualified to discuss nutrition with their patients in any meaningful way. And so there's nothing happening, and so we have to change this, or how do we expect the physicians to emphasize or even understand the benefits of nutrition and exercise when we aren't teaching them at the very fundamental levels that it's relevant?
It's a shame on us. Mike, how are we going to fix this?
We've said it already. So it's a culture change thing, but we have to do it.
So we need to lead by example.
Exactly. We need to walk the walk as well as talk the talk. So tricky. But there's an element by which physician leadership is convincing to patients, and I think that's going to be a major theme of this kind of cultural change, in the same way as it was for smoking.
Now, there's quite a lot of obesity amongst healthcare providers. If we go to work, in stressful environments, one of the ways to find succour at night is the tin of biscuits or the chocolates, and so there's quite a lot of increased BMIs. But actually, if we take the world we work in, intensive care, for example, there's a lot of activity. So if I step count covering the main unit when I was doing it, it was a 10,000 step day easy. So which of those are the priorities we need to work on there by leading by example?
I think the activity story is the really dominant story. It's starting to get a little bit nuanced. So people know they're supposed to lose weight, they're supposed to exercise. But I think we need to explain activity. That the trump card is staying active. The health benefits are huge, and the healthcare providers are buying into this and doing it.
And Monty, if I could even take that further, and I mentioned this earlier, Denny said it exactly right. The activity is far more than important than the weight loss is. We know, as I mentioned in my lecture, as your BMI increases, your survival from lung injury, your survival from ICU increases out to a BMI of 40. And for every 1 point...
I'm just going to pause there for a second. You've got that right. So you're a bit heavier, a bit fatter. If you become very unwell, you've got a better chance
of surviving serious illness. We think it's your metabolic reserve.
Okay.
And in fact, for every 1 point your BMI drops, when, say, you enter the ICU or have a major operation, you have a 7% less chance of recovering a meaningful functional quality of life when you leave. So that a person whose BMI is 30 is 60% more likely to recover meaningful functional quality of life after an ICU stay, for instance, than someone whose BMI is a healthy 22, because they don't have the reserve to survive the insult.
Irrespective of their baseline physical function, or is that a known unknown?
And that's an unknown.
Okay.
It's an unknown in critical care, but interestingly, in the epidemiology all-cause mortality outcome, it's known that actually if you control for exercise or exercise capacity or fitness, then there's no difference across the BMI scales.
Until you get low.
Until you get low.
Yep.
So if you... so basically, overweight fit individuals do as well as normal weight fit individuals. But if your fitness is low, if you're overweight, you do very poorly.
Okay. So
and those often compound each other, because sometimes very overweight people do very little activity. But actually, if you're overweight and do activity, you will do much better than someone who's underweight and doesn't do activity.
And I think that uncoupling is a very valuable message.
Yes.
So having very slowly run a handful of marathons, it is really striking. There's some big folk run past you.
Yeah.
But they're clearly very, very fit, and they're putting in good times. So the fact that fitness and obesity are essentially unrelated is a really important message.
So one last time, if you're worried about your weight and you're inactive, the most important thing to do is to go for a walk, not go on a diet in the first instance.
Amen.
Absolutely.
Yeah.
Nobody
and
should
a
diet
lot of
before
literature has shown that calorie-controlled diets do not promote long-term weight loss. You're much better to change your behaviour by improving your activity.
So if you're struggling to give up the donuts, just
go for a run.
Park further away from the donut shop
Exactly.
Keep enjoying the donuts for now, and walk further to the donuts.
And have a glass of milk with your donut, because if you can get your protein intake up, you're going to do better.
There we go. Great messages.
And the last thing, in case you have small children, is that for children the physical activity is hugely important.
Yep.
The ones that don't do the activity do poorly at school.
Yep.
They have poor educational outcomes on all standardised tests, and if you make them exercise more, they do better, and they'll get into that Ivy League college.
That's another cultural thing. In the UK, we've seen quite a lot of backing off of supporting sports activities at school, of activity breaks, of playgrounds. That's shocking, isn't it? We have to reverse that too. We've got a campaign for that to be fully reversed.
It's a disaster, and there was a fascinating study. I think it was a Southern Scottish school. They did an hour a day of exercise, so they did less lessons. An hour a day of exercise, just walking around the local block, and educational attainment shot up. So just keeping active is an incredibly strong stimulus.
Hugely important.
So if your child is walking distance or cycling distance to school, the kind thing to do to them is to let them walk and cycle in the rain, not to drop them off.
Absolutely.
Okay, Paul?
Amen. And I think, too, more and more is coming out around the nutritional education of our children needs to start when they're children. Because, as we know, obesity is the fastest growing epidemic in our country, at least, and around the world. Yeah. And a lot of it is, and I have even trained medical professionals say to me all the time, I know I'm having surgery, or I know I'm having this cancer chemotherapy. I don't know what I should be eating to prepare for this. So even medical professionals don't know what good nutrition is. They don't know they need more protein to heal. They don't know they have greater protein requirements after injury and illness. This is not fundamental knowledge to people.
These are basic life skills.
These are basic life skills.
Yep.
So takeaway message, young children, good breakfast, good healthy breakfast. Mm-hmm. Let them walk to school. If you're worried about them walking to school on their own, walk with them.
Exactly.
Any other
good
messages?
For everyone.
It's good for you too. Yep.
And last take-home messages, Mike?
It's for us to change the world and change the culture.
Okay. You've got the rest of the evening to do that. Denny?
Move more.
Move more.
Yeah. And we no malnourished patient should ever come to elective surgery in the world again. We have to start screening. We have to start identifying, and then we have to be treating. It's a crime if people who are malnourished, as they are now, are coming to our operating rooms for elective procedures. That has to stop.
Excellent. Well, thank you very much indeed for another wonderful session, Dr. Paul Wischmeyer, Dr. Denny Levett. Mike, enjoy the rest of the evening here. Look forward to seeing you tomorrow at EBPOM USA, the first perioperative practicum. Please don't forget to subscribe to our podcasts, and you can listen to the live stream of this meeting for the next day. So go to www.topmedtalk.com. If you've got a podcatcher, put Top Med Talk in and subscribe, and you'll get these on a regular basis. If you don't know what I'm talking about, look it up on the internet or ask a child to show you. Thanks very much. Bye-bye.
Thanks, Monty.
Thanks, Monty.
Thank you.
Top Med Talk.